Hello and welcome to another episode of the Daily Remedy Podcast. Today we're here with Mr. Bill Murphy, chronic pain patient and chronic pain patient advocate. He is here to tell his story both as a patient and his journey of advocacy. And with that, I'd like to welcome Bill. Thank you for joining us.
Hi, Dr. Joshi. Thank you for having me.
So, Bill, let's start at the beginning. Tell us about your own personal medical history and what led you towards advocacy.
Okay, so I had emergency abdominal surgery back in 1994. Um, Long story short, it ended up being a ruptured appendix. The surgeon, let's just say things didn't go well. Uh, Surgery took forever. First of all, I had to wait hours for the surgery to begin, for them to figure out that it might be the appendix. In any case, again, long story short, surgery did not go well. I ended up in the hospital for about 3 weeks. Um, when I left, I ended up having issues with abdominal adhesions. 6 months later, I was rushed in with a bowel obstruction. Had to have surgery for that. And then since then, I've had several more surgeries for bowel obstructions. And it it kind of developed into what a specialist in Boston Mass Hospital said was to the level of a disease, abdominal adhesion disease. So since that about that time, I lived with constant kinking of the small bowel, bowel obstructions. I used to end up in the emergency room all the time. But over the years, I've learned to I've learned what the identifiers are for it coming on. So I have some therapies I can apply myself to hopefully avoid having to go to the hospital. Um, and Yeah, it's just a chronic condition that they can't. The only option they have for fixing it is more surgery. But doctors have said the last thing you want to do is surgery on your abdomen at this point.
And
It
for
was good.
For those not familiar with the term of adhesions, think of it almost like there's internal scarring where different parts of your intestines are sticking to the wall or sticking to each other, and they're causing complications like obstruction, like malformations. And typically, what you would do is you would come in and remove the scar tissue just like you would externally, only you have to do it inside of the bowel. So for those of you not familiar with the term adhesions, think of it almost like internal scar tissue, even though there's a little bit of difference there. But I think for your example, I think that comparison should suffice.
Yes, and it's interesting because early on they told me that I was somewhat of an over healer, and I thought that was a good thing. It sounds like a good thing, but obviously in the case of adhesions, if it grows out of control, it's not a good thing. So again, you end up with this. I do with this constant kinking, and then small bowel obstructions, and then full blown obstructions, where obviously at that point I'm in the hospital.
So
So good.
what is the management for that? You obviously are dealing with symptoms like pain, discomfort, constipation, intermittent bowels of diarrhea. Symptomatically, what are you taking to help relieve and improve your quality of life?
So I do. In the early years, I was on a lot of different medication. Um, Many of them at the same time. I was on muscle relaxers. I was on uh, anti-anxiety medications. I was on gabapentin, Topamax. I mean, the list goes on and on. But over the years, I've seen many specialists. You kind of learn what helps and what doesn't help. I've also learned that there are some therapies I can do myself that help the situation. Things like deep. It's a form of deep tissue massage. Only I use a back massager, and I kind of dig that into my abdomen several times a day, just trying to keep things moving. Um, I do all kinds of stretching. I use a TENS machine. I use an electrical muscle stimulation machine. And then Since that time, I've been placed on, when they determined that nothing else would help with the pain, I've been placed on a low dose opioid regimen.
So let's talk about that because I think that's when the story gets quite complicated. Because in your situation, you have a well known incident, the surgery and the surgical complications. And it's well known that post surgical adhesions can cause significant discomfort, of which one of the most common symptoms is chronic pain. At the time, you were treated with muscle relaxants, other medications like anti anxiety medications, and low dose opioids. At which point did you start to notice changing perceptions in your pain management and your overall treatment regimen?
Well, as I'm sure many patients have told you, it was shortly after the CDC came out with their new opioid prescribing guidelines in 2016. The physician I see, I've been seeing him every month since 2001, literally every month. And it was on a visit shortly following the CDC, the release of the CDC guidelines, where he had a discussion with me about needing to reduce the amount of medication I was on. Now, I'm very fortunate because I have a very understanding physician. He knows me very well, and he never pushed that as something that needed to be done. He more or less put it out there. We had a discussion about it. He kind of proposed it as something that I could pursue if I thought it might be something I was interested in. However, if I didn't want to, if I didn't think it would be helpful, that he understood and that he wouldn't force me to do that. So, again, I'm one of the fortunate ones because I have that supportive position. However, I have on my own, just because of the ongoing concerns that I have, especially given the patients that I've advocated for and seen what they've gone through. I have concerns that one day this decision may not be his own. He may be forced by either his own practice, the folks that he works for, or by the state medical board or by the DEA to forcibly taper me. So I've voluntarily tapered myself several times over the years with his support. And I've been able to do it gradually in small amounts so that I've always been, and as I've done that though, I've also introduced a new therapy that I come across. For example, the last one was this deep tissue massaging. The one prior to that was the use of TENS, the transcutaneous electrical nerve stimulation. And so with the introduction of that new therapy, that helped me to manage my pain a little bit better, which also made it a bit easier for me to taper back my medication. So I've done that several times over the years, so that's where I am now.
That's a very interesting story. And first off, congratulations on successfully working with your physician to optimize your care. I think it's very commendable. I want to delve into that a little bit further. Besides your medical records, your past surgical history, how did you communicate with your physician to foster such a trusting relationship? Are there certain nuggets you can pull out over the course of that relationship that led to a trusting relationship where there was a mutual understanding that tapering should be done at your own clinical discretion and not forced?
Well, I do think I'm in a very unique situation. The physician that I had coming out of the hospital was a very attuned to pain management. This was well before the CDC guidelines came out in 2016. Um, he was also from Canada. When he moved on to a new position, he filled his own position where he had at this primary care practice with his choice of person. It was another gentleman from Canada, another physician. When he came in, he worked with my prior physician to learn about who I was, He got the history from him, and in our very first appointment, excuse me, I explained to him my concerns. I explained to him a little bit about my history, which he was well aware of at that point. So it's a unique situation because he came in not questioning me at all. Um, he got the word of the doctor who was leaving, who he knew well, so he trusted in his word. And then, so we kind of got off on the right foot. Probably a situation that, well, as I know, not a situation that many patients have been afforded.
What do you think other chronic pain patients can learn from your situation that might help them to foster, whether it's trust, credibility, whatever is that right term that helps to exemplify the relationship that you have with your initial physician and your subsequent physician that other chronic pain patients can use?
Well, I think first of all, excuse me, uh, I I continue to see my physician every month. Uh, they both physicians made me aware that I didn't need to do that. They were willing to see me every third month, early on, even every other 6 months. But I wanted to continue to see him every month in the early years because I was still very sick and very unfamiliar with what was going on. So I wanted to stay in close touch with him to make sure that if something came up, we were communicating. But I think for a lot of patients who extended the time between appointments, I think it allowed for them to lose some touch, some communication with their physician, and and especially given the pressures that have been placed on physicians since the guidelines came out, uh, they now have that pressure on them to reduce the use of opioids. They don't know the patient as well. They don't see them as frequently. When they do see them, they're talking about urine drug samples. They're talking about pill counts. So it becomes somewhat of an adversarial relationship. Whereas with me, seeing the physician every month over all these years, when he'd ask for a urine drug test or a pill count, to me it was of no concern. I was very willing to participate in that process. I had nothing to hide, which generally chronic pain patients do not have anything to hide. But because we maintained that monthly appointment and that close relationship, when those sorts of things came up, those questions, I wasn't offended by them. I wasn't concerned by them.
Now, let's touch on that because I think, in terms of your personality and just your overall predisposition and getting to know you, you seem very understanding. And I think that's a strength of yours, particularly in this hyper stigmatized climate that we live in. When these questions were asked, can you take a urine drug screen? Can you provide a pill count? Talk through what was going through your mind. Did you ever feel defensive and then thought the better of it? Did you come in knowing this was the par for the course and you were doing this almost as a way to show trust, to verify your trust? Talk a little bit about your mindset during these moments when you had to verify your medication use.
Well, again, and I might be again in a unique situation. Even my prior physician used to do those tests periodically. Now we're talking prior to even 1998. Um, so to me, it was just part of the process. It wasn't something new to us. Um, so now after the guidelines came out, I understood that this was all being done in a different context. So I knew the reasons for it being done now. I knew there was a different. I always understood the reasons, but I knew that there was something else at play now. But again, because I had known him for so long, seen him every month for so many years, um, and by the way, I've also been very open with him about my advocacy work. So he understands. I mean, I've discussed with him many of my patient experiences, experiences with other physicians trying to advocate for patients, some of the successes I've had, some of the failures I've had. Uh, he's tried to give me some of his insight from a physician's perspective about why certain things may have been done that I may not have been very understanding of. Um, so I guess but again, for me, the randomness of these pill counts and drug tests, it just never was a big issue for me, a big concern for me. So when
I
I
think
advocate for patients, I try to reinforce with them that if you can get beyond that initial feeling that this gives you, it can actually work to your advantage if you participate willingly and just be open about it.
so. Let's touch on that, and I want to play devil's advocate and maybe push you a little bit on that point, just because I really admire your perspective. I know some individuals, just more or less on their personality type, may feel like this is an affront on my trust, on my patient autonomy, and I don't feel like I should be subjected to this even though I didn't do anything wrong. It's a natural inclination. I would feel that. I know a lot of people that would feel that. And sometimes I feel like it's personality based. Sometimes I feel like it's clinically based, or perhaps there's a demographic play involved. For those patients who had that natural predisposition, what sort of advice would you give them?
Well, I think a lot of this is it kind of goes back to even the way we patients prefer to be treated on an individualized basis. I think the how you react and how you manage the conversation around these random pill counts and drug tests is also individualized to the physician and the patient. A lot of how a patient can feel about having to submit to these things can be how the physician presents that to them, uh, and also how strong that relationship is to begin with. Um, Again, I advocate for patients. I've sat in the office with patients and their physicians many, many times, and I've seen physicians who do not handle that discussion very well at all. Um, they present the need to do these tests in a way that certainly would make a patient feel like, or put them on the defensive, make them feel like they're being suspected of doing something wrong. I've also seen patients not handle that discussion well, where a physician was trying to put it across in a positive way, but because their defenses go up immediately, the discussion kind of goes down at that point.
I love the way you phrase that because it's a bilateral conversation and the issue really touches on both sides. I want to put all of it together, but I want to go piece by piece. So we first talked about patience and a tendency to become defensive. Let's now talk about physicians and their tendency, our tendency to now incorporate more legal liability into the clinical decision making. I think we all know that there's been fundamental changes in clinical decision making as a result of the pressures put on by legislators and agencies like the DEA when it comes to the prescribing of medications like prescription opioids. For physicians who now may ask for more urine drug screens or be less willing to provide certain prescription opioids and balancing the legal and medical concerns, one, what's a great way to present that conversation? And then two, what have you seen physicians do to effectively balance the legal and medical concerns in a way that's beneficial to the patient? I know it's a long question, but a two-part question. I'd love to get your feedback on that.
Sure, and yeah, it's a complicated one because again, a lot of this goes back to the person, the individual, again, both on both sides of the table. Some people have a very positive way about them in communicating with people, just in generally speaking, and that has a way of influencing patients when they're having this conversation, influencing the way they're going to respond. I mean, I've seen physicians just be very kind of cold about that discussion and just lay it out as this is something that needs to be done, regardless of whether I believe in it or not. We're going to do it. Um, I've actually seen physicians have their nurses or their medical assistants take over that discussion. I've seen physicians leave the room and leave that discussion up to the medical assistant. Um, and I think when that happens, you're dealing with a totally different dynamic at that point. If the patient has a relationship with that physician and now they've stepped out of the room, now they're hearing this message from a medical assistant who they don't know well, and the message is already putting their defenses up. And now they're hearing it from someone they don't know well. It's just not a good way to go about it. I think physicians who explain it from a human perspective, that they both are in a difficult position, the physician and the patient, and the physician can explain that I need to do this. I don't always see the value in doing this, although there can be for both of us if we just willingly participate in this process. It's a very tough situation. I understand where patients are coming from, especially those who have been through physician after physician after physician, um, been let go of practices, either physicians retiring or letting them go for other reasons. They don't have that relationship in place, and now they're being asked for urine drug tests and pill counts. That's not a great thing to have happen. Um, Again, I'm not. I'm in a unique position. I've had the same position for so many years. Um, I wish everyone could have what I have, uh, but it's not par for the course. That's for sure.
Yeah. Let me ask you an instructive question. Given your experience serving as a patient advocate and having a long term relationship with just a few physicians, when the conversation goes quote unquote south, when either the physician leaves the room, leaving the patient hanging with a medical assistant or somebody unfamiliar to the patient, or the patient becomes defensive, what are some corrective actions that you've seen work in the past?
Well, part of my process is I always, prior to advocating for a patient, I always meet with them first. So I get to know a little bit about them, what their medical history is. Um, but I also prepare them for the discussion we're going to have with the physician. So I'll always make sure that they know that, first of all, I'm never going to argue with the physician. I'm never going to raise my voice with the physician. We're always going to maintain just a very level headed approach to this entire thing. I'll explain to the patient that what I may say oftentimes may not be what you might want me to say, but please trust in what I'm doing. Please trust in my process, because I believe that if we follow this along, if you go along with this with me on this, that we will get a more positive result. So, for example, a very specific one. I've had many physicians talk to a patient about, and I've known this going in, that the patient was going to be tapered. So when the physician explains that to the patient, I'll sit back. I always sit off to the side with a notebook and a pen. So I'll sit back, and at that point, I'll just say, "Oh, okay. So I'm certain then that the patient must have failed a urine drug test then," and I'll have my pen ready to make notes. And at that point, more often than not, the patient hadn't failed a urine drug test. So the physician would respond in kind, "No, that wasn't the case. That didn't happen." So I'll then suggest that, okay, then they obviously must have failed a random pill count. And again, more often than not, the patient hadn't failed a pill count. So now I start to see the physician become a little bit uncomfortable with where this discussion is going, because I'm just asking very innocent questions, assuming that something went wrong with the patient testing to lead the physician to this decision. Um, and then uh, at that point, I'm asking the patient to just go with me on this. Let's not, push this thing too hard. I'm just trying to bring the physician along with me and the patient to see where the patient's coming from. So it's kind of a again it's always an individual thing. I'm always reading the physician at that point to see what his reaction to my questions might be, so that would lead to where I go from there with my next question.
Do you ever encounter physicians not being fully forthright in how they're thinking or how they're making clinical decisions?
Yeah, absolutely. The real unfortunate thing is that many physicians, I believe, assume that patients aren't as aware of what's going on relative to guidelines, state laws, state regulations. So I've sat in a room with physicians who would tell a patient outright, New Hampshire law, so I'm talking about my state, New Hampshire law doesn't allow me to prescribe opioids to you any longer. I've literally sat there and heard them say that. So I then, at that point, explained to the physician that I'm not sure what you're talking about, but I know there are no laws that spell that out. Can you help me understand where you're coming from? I've had other physicians uh, tell patients that the CDC guidelines do not allow me to prescribe opioids to you, when in fact, obviously, the CDC, the guidelines were just guidelines. We all know how they were misinterpreted, but in that discussion, they were just guidelines. They did not dictate how this physician should treat this patient. So I've had many, many cases where physicians have done those sorts of things to patients, expecting that they would just go along with what they were saying.
In your opinion, would it almost be better if the physician was honest and simply saying, I don't want to take the legal liability?
Yeah, absolutely. I think, it's something that we should all be doing every day in all our discussions,
Yeah.
right? It's just being genuine and honest. But no, I think patients, especially nowadays, patients know this. They understand that physicians are being persecuted, not just prosecuted, but persecuted for treating patients, especially with where opioids are concerned. Patients know this is happening. So if a physician explains that up front, and I've been witness to that as well. Many physicians very good about this, and they'll explain that up front, that their concern is, I got a letter from the DEA, or the practice I work for is implementing this policy. It's out of my control. This is not something I support, but I need to do this. That sort of thing. Patients, I mean, in the end, when they leave the room that day, they still face the reality of being forcibly tapered, or in some cases abruptly cut off. But at least they understand that the physician's not trying to sell them a story that just isn't true.
Yeah.
They understand what the predicament the physician is in.
It's interesting you say that because it's almost as though physicians are scared to tell patients that they have this legal concern in their minds. And in your opinion, advocating for patients, having a trusting relationship, it's almost better if physicians were just honest and told the cold truth that I don't feel comfortable or I'm forced to follow a policy that I may not agree with.
Yeah, absolutely. I think that's the best approach. I worked with one physician who his practice had been merged in with a larger practice, with a large hospital system here in New Hampshire. This physician was a very, very good person, treated his patients very kindly for years. Several of them were on long-term opioid therapy. Uh, when he moved into this larger hospital system, they forced a policy on him that said we are doing away with long-term opioid therapy for all patients. He was very, very upfront and honest with all of his patients. He explained to them what was going on, the fact that he didn't agree with it. But he also took the time to work with them on finding them a new physician in every
Yeah.
case outside of that practice. So he went the extra yard to help these patients out in that respect. It didn't work
Yeah.
out for every patient, but at least they understood he was doing what he could for them.
Yeah. No, that's certainly wise words from a tenured patient advocate, and I appreciate your perspective. In the remaining time that we have, I want to focus on empowering patients. In your experience dealing with patients who have navigated the charts quite well, those that have had their fair share of miscues, let's talk about pre visit preparation, the communication during the visit, and follow ups in three different parts. What can patients do in each of the three phases to optimize patient care for themselves and physician trust?
Um, well, I think first of all, one thing I always recommend every patient does is maintain that monthly appointment. As hard as that might be for a lot of patients, maintain that monthly appointment. Uh, in doing so, develop as strong a relationship as you can with that physician. I also tell patients, I'll be very honest. I tell them, be as nice as you can uh, with everyone you interact with in the facility, uh, from the front office staff to the nurses, the medical assistants, the physicians, anyone. Just always be as polite and nice as you can, because uh, anything you do, in especially in the current environment, could end up painting a negative picture about you with that person. I tell patients prior to every meeting, every appointment, try your best to bring someone with you to every appointment, whether it be an advocate, a family member, a friend, someone who understands your situation. Even if they're not there to advocate for you, just so that there's another person in the room. It's always more difficult if someone is trying to deliver you a tough or needs to deliver you a tough message. Uh, they're going to go about it in a different way if there's somebody else in the room with you. So I always recommend bring someone with you. Um, I also recommend that every patient, every appointment you leave, get a copy of the medical records for that day, the notes, files, everything, so that you always have them. Read up on them, read the notes that were written about the appointment. If you have questions about them, follow up with the physician to ask about what he wrote, what he or she wrote. Um, and I'm trying to think. I know the question was longer than that, but
No, I appreciate that. Before, during, and after. I really like this example of reading the notes and discussing the notes, because that's so critical. So many chronic pain patients will bring in a clinical study or some sort of reference material, but they won't look at the notes. They won't see what is being written about them. And by taking the notes on a clinic by clinic visit basis, you're effectively telling the clinicians that this is a two-way relationship. What I communicate to you reflects what is written about me. And I love that. It's great advice.
yeah, to be honest with you, I think the notes are the most important thing you can make sure you read and understand. Uh, the other parts about the follow up, or the doctor's records following an appointment, is more just them checking boxes. It's the notes where they put into words how they felt the appointment went, what they witnessed during the appointment, what they talked about with the patient, that sort of thing. And lots of times you can see things in those notes that confuse you. You aren't sure what they meant by even something as simple as patient denies a certain symptom. That word deny makes it sound like you're saying I didn't do that bad thing, whereas in medical speak, deny simply means you're saying no, I didn't have that pain, for example, right? So I think reading the notes is very important. Following up with questions to the physician, it lets them know that you are reading these. You are taking the time to understand what they're writing about you, and you're these appointments, these string of appointments, they're not just individual happenings. They're not disconnected from each other. They're part of a process over years if you maintain that relationship.
That's great advice, and I think that's something all chronic pain patients should follow. Bill, I want to thank you so much for your time. In the last few words, can you let those listening who may want to get a hold of you or may want to speak to you further about your advocacy, what is the best way they can get a hold of you?
The best way is they can find me on Twitter. They can find me on Facebook. Everything I do on Facebook is public posts. I don't nothing is private, so anybody can read anything I post. Um, I it's interesting because my advocacy work, it's all voluntary. I've never advertised anything. It's all been word of mouth over the years. So somehow my number gets out there, even if I didn't want it to. So I'm sure if they just asked around, they'd be able to get my number and my email address. I always get back to people, even if I'm overloaded at the time and can't deal with every issue that comes up. I'll at least send them links to information that I think they will find helpful, that sort of thing. So yeah, if they ask around, if they go into, for example, the Doctor Patient Forum on
Hmm.
Facebook, the New Hampshire Doctor Patient Forum, they'll find me there. They can message me there, that sort of thing.
Perfect. Bill, thank you so much for your time. I appreciate everything.